definition of it. I'll say right off the bat that's a bit controversial. Prevalence, why it happens, what's the pathophysiology, why it's important, what's the prognosis with it, and then getting into what can be done in the clinic. So the same things you've heard around screening and assessment and treatment, and then really wrapping it up with some case studies. So by the end, you're going to be comfortable with screening for malnutrition and cirrhosis. One of the muscle mass or muscle function tests is thinking about what you might use in your own practice, and then asking about some common barriers to nutrient intake, and then coming up with a basic nutrition prescription that you can actually give your patients when they're in the clinic. Okay, so that's what we would like you to get out of this. And I don't probably need to go into this much, but obviously cirrhosis is progressive scarring of the liver, and it can result from hepatocellular disorders or cholestatic disorders. And the reason that what is the little cross thing that's happening? The reason, because you had a Mac too, maybe. No? Okay. Mine was made on a Mac, but cirrhosis is just going to become a greater and greater problem. We're getting obesity epidemic with NAFLD or fatty liver disease that's increasing. It's a leading cause of death already. For those of you who are in the hospital setting itself, major cause of hospitalization and readmissions as well. And the majority of them don't have a curative option as far as transplant. So malnutrition is such an important focus because it's something that's potentially modifiable. Something that we can do for the patients and give them a bit of control over their condition and over their disease. So let's start the first area with how do we define malnutrition in this population. And we've taken a little bit of a different stand on muscle, like with the sarcopenia, because I think it's one of the real defining features of malnutrition in a cirrhotic population. Dr. Raymond and I led a review article in 2017 trying to tease out this issue of what is nutrition screening and assessment and what is malnutrition and cirrhosis. And this is just the different parameters that you will see across the various malnutrition assessment tools that are used and the guidelines that are used. So by the American Association and the European Association, and what you can see, the shaded areas are what's common. So weight loss is a common one. Most common is muscle mass loss. So that's a really objective feature of malnutrition. And then body mass index is the other one that comes up. You can see talking about food intake, looking at subcutaneous muscle fat loss, like you've already heard about. And the subjective global assessment was looked at in one just as a main tool as well. Oh no! Oh no! That's a problem because there's words in this. So we don't have a Mac adapter, do we? Okay, this slide, I hope there's not a lot of this slide is meant to say, but this slide is meant to say that there are interrelated concepts, and the interrelated concepts are malnutrition is very closely linked to sarcopenia, as you've heard about, which is muscle mass loss, but it's also linked to other concepts that you would have heard about, such as disability, for example, or frailty. Physical frailty is a really big thing in the cirrhosis world right now. And so I think all of these things, what they have in common is muscle and muscle health. And so that's, in the cirrhosis world, been a really, really important tool. And we call that sarcopenia, or muscle wasting. And the definition across the board is usually less than, muscle mass less than 2 standard deviations of the mean muscle mass of healthy adults. But there's various ways of defining it. We'll also look at myosteatosis, which we'll define here, but it's fat infiltration, so looking at the quality of the muscle. So you've got muscle, but that muscle is full of all fat. That's not quality muscle. And then sarcopenic obesity is another concept we'll bring up, which is when patients have muscle loss but are also overweight. And as has been brought up, there's ways of looking at sarcopenia that vary, and there's some tools that you use in the clinic, and then there's some tools that we use for research. And a lot of the data that we have is on the researchy tools, the ones that you'll use in the clinic. Dr. Raymond pointed out really nicely, so looking at things like anthropometry, like the mid-arm muscle circumference, looking at muscle function with a hand grip dynamometer, and then looking at frailty tests, which are really hot in the area of cirrhosis. So things like, can the patient sit up or stand up from a chair? So just simple tests like that to test muscle function. And then, of course, research tools. The really big one is CT, and we'll go into that in a sec as well. So we have cutoffs for mid-arm muscle circumference, and we have cutoffs for hand grip strength, and those are available in the publication that we did as well as online. And so it's just a matter, I guess, of choosing, and Vanessa will go into this in a little more detail, choosing what you might use in your population. It sounds like in the malnutrition clinic you guys are using MAMC and hand grip strength, which are probably the most common ones. CT has really taken over as far as the research tool, and there's a ton of research in cirrhosis. Are you guys familiar with these kind of scans? Have you seen them at all in other presentations, probably? Do you have a picture? Okay, so this CT scan is done using a program called Slice-O-Matic and MATLAB, and you can see that it divides based on what the Hounsfield units are, it'll divide the tissues into different colors. And so you've got your subcutaneous fat, you've got your visceral fat in yellow here, and then you've got your muscle. Okay, and so that differentiates the amount and allows you to really quantify the body composition. In our studies, we use the L3, the cut at the third lumbar vertebra, because it's the most reflective of the whole body muscle mass. And there are cutoffs in cirrhosis that have been developed using over 1,000 patients from across different sites. And I don't expect you to know the cutoffs, but just to know that there definitely are fairly well validated cutoffs that correlate with mortality. This is what I'm talking about with the muscle quality. So you can actually look at the degree of fat infiltration within the muscle itself. And that muscle, when it's got fat in it, does not function very well, so it's not as strong. So that's prognostically important. And this term sarcopenic obesity, that's putting two of the major epidemics together, which is patients losing muscle but also being overweight. And our patients can be malnourished, or sarcopenic as the most objective feature, and be overweight. And that obviously is a problem because it's tough. They hide all of that underneath the fat. This was a review article that we wrote, and this area again is just developing, and we don't actually know the clear definitions for this. The easiest would be to take what we've done for the most part is low muscle mass for sarcopenia, defined by either mid-arm muscle circumference or by the CT scans, and then obesity. In general, in our population, is a body mass index of over 30, but if you look at Asian cutoffs, it's over 25. So again, it really depends on where you're at. And this is an example just to look at two patients, just to show you how this might be helpful, because these two patients have an identical BMI when you look at them on the outside, so 32, but you can see the differences in the amount of red. It's particularly marked here, right? So this patient has much more muscle mass than this patient, and we wouldn't have necessarily known that unless we would have done a scan or perhaps tested function in some way to see what the muscle was actually doing. Okay, so how common is malnutrition? How common do you guys think? I told you we don't really know how to define it, but so that might have a little bit of a challenge in determining what the prevalence is, because it's affected by the tool that you use. But in our cirrhosis patients, is it less than 20%? Is it 20 to 50%? Is it over 50%? Depends a bit on which group they are. It's common. I mean, some studies, 80% of the patients on the transplant list are malnourished. And it depends again on what definition you're using. This was a study using CT that we did back in 2012, and various studies have replicated very similar results. Sarcopenia might not be the best tool for women. It's not as prevalent in women as it is in men, which is really interesting. And the Child-Pugh class, which the liver group will be familiar with, but it's a way of assessing liver disease severity. And so worsening severity is when you're at the C, the compensated patients who don't have ascites or anything, they're the A's. So you can see that the prevalence really increases quite significantly. By the time you're at C, you are definitely sarcopenic and malnourished. Okay? So the prevalence is very high of malnutrition, significantly higher, I would say, than the inflammatory bowel disease group that we're dealing with. Okay, Vanessa's going to take you a little bit through pathogenesis.
Okay.
It works.
So with Puneeta's really good introduction,
We've got this beautiful
hilarious slide. But the first first category, we've sub-segmented pathophysiology into 4 categories. So the first category is reduced oral intake. So what I was hoping to get is if anybody has ideas as to why a patient with cirrhosis might struggle with eating enough food, whether it's volume or nutrient density. Does anyone have any suggestions or ideas?
Sodium restricted diets and everything's awful.
Yeah, so poor palatability of recommended diets. Yeah, that's certainly one. Yeah.
If they have a large amount of ascites, they just generally don't want to eat.
Right, there's less room for that food to go in, so they have significant early satiety. Any other ideas?
If they're still drinking, they're getting calories from alcohol, not nutrition.
Absolutely. So all really good ideas or good facts in reality. But early satiety, as we mentioned, due to ascites. Anorexia, just that really suppressed appetite, whether it's due to increased cytokine production, low mood, etc. Dysgeusia, so that speaks to the unpalatable diets, but also changes that go on. Patients don't enjoy the taste of certain foods anymore. I've had at least 200 patients tell me, I used to love steak and now I can't even look at it. The amount of times I've heard that. So it's a big problem. And then we also see frequent hospitalizations and procedure requirements. These patients are maybe coming in for paracentesis every week. They're being asked to fast before the paracentesis. They'll get to DI and not be admitted for 4 or 5 hours from their scheduled time. So the number of hours where they're fasting is really prolonged and extended. Oops. And now, next subject is malabsorption. I gave one hint already. But can anyone suggest reasons why these patients are, now they're not only not eating enough, but how come they're not absorbing what they are eating? If you were fast, you saw it.
Something about bile acids.
Yeah, exactly. So bile acid deficiency, we see portal systemic shunting, decreased production of bile acids, so we're seeing less absorption of fat-based calories. So now we're not eating as much, and now we're not absorbing what we are eating. So we're seeing this real compounding issue. And then altered intestinal flora. So patients are on lactulose, so they have frequent bowel movements. Their intestinal microflora can change, or frequent use of antibiotics, which can change that as well. And then portal hypertensive enteropathy and pancreatic insufficiency as well in alcoholism can further fat malabsorption. Oh, I keep doing that. How about altered macronutrient metabolism? Does anyone know what that means? Kind of how we're processing the nutrients we take in our body, whether it's in the liver or systemically throughout the body. It's kind of a tricky one.
Have you guys heard of the term accelerated starvation? That these guys are in a state of accelerated starvation? Yeah.
So basically, one figure I heard is, typical physiology, an individual could go about 72 hours before we flip into our starvation response, where we start to mobilize our glycogen stores, which is our main storage form of carbohydrate. So that's a healthy liver and healthy muscle mass can provide for up to 72 hours. In patients with liver disease, that window of time is as short as 12 hours, maybe even shorter. And so even an overnight fast is enough opportunity for the body to start flipping into starvation response. So we see decreased hepatic glycogen stores. The liver is not as able to store carbohydrate in the liver. We have less muscle mass, so the muscle is also not storing that carbohydrate. And so we're seeing a mobilization of glucose and amino acids out of our muscle tissue instead. So gluconeogenesis is I don't know if you guys all think back to your university days and biochemistry 200. Gluconeogenesis is the production of glucose from non-carbohydrate containing products. So we take those amino acids from our precious muscles and build glucose units. And then decreased protein levels. Patients undergoing paracentesis in particular, they're draining out a lot of fluid out of their abdomen, and with that fluid comes protein. So lots of reasons why they're behind the 8 ball. And then the last segment is hypermetabolism. So these patients are like inefficient furnaces. They're burning up more energy than they normally do or than they should. Any ideas why we're seeing hypermetabolic patients? Again, this is kind of a technical one. but an increase in cytokines and inflammation. So similar to reports in IBD. When you're inflamed, you're burning through more energy, and bacterial translocation and frequent infections. You look at spontaneous bacterial peritonitis being a big reason for hospitalization and admissions. These patients are very prone to increased metabolic rate.
Yeah, so lots of them have leaky guts and they're transmitting bacteria very easily. And so this, Dr. Raymond brought this up as well, just mentioning that all of those factors that Vanessa just went through contribute to malnutrition and sarcopenia, but obviously it's more than that. It's that they're not moving, and they're not living in hospital, and they're not living at home, that they have low testosterone levels, the majority of them, which is obviously a major contributor to low muscle mass. And then there's a really interesting connection between having high ammonia levels and actually having direct toxicity to the muscle as well. Okay, and they're not even as able to break down their ammonia properly. So those two things are connected. So if you're more malnourished, you're more likely to have hepatic encephalopathy or confusion. Okay, so why is this actually important? And why it's important, I can summarize it by saying it affects everything. It just affects all of your morbidity and mortality. But I think it's really important because it's potentially modifiable. It's something we can do something about. And it independently influences the risk of having reduced survival after transplant, reduced survival on the waiting list for transplant. Even after surgeries, we've looked at studies with hepatocellular carcinoma and resection. It increases the complications if you're malnourished with those kind of surgeries as well. This was a meta-analysis that goes beyond sort of just the CT-based studies, which the majority of them are. This was a student that, again, Matri and I have supervised. And it's a long slide of various studies, but they've all looked at different kinds of nutritional assessment tools. So whether it be CT-based sarcopenia, your mid-arm muscle circumference, a tool that Vanessa will tell you about, the RFH or Royal Free Hospital SGA, hand grip strength, or various tools, all of them increase mortality in patients who are malnourished, so better survival in the nourished patients. So no matter how you measure it, being malnourished is not good news in a cirrhotic patient. This is looking at a study that was done way back by one of our colleagues in Italy back in 1996. She looked at almost 1,000 patients and did mid-arm muscle circumference on them. Sarcopenic patients die more just by using this simple measure. And then with our fancy tests, more recently, definitely sarcopenic patients die more than non-sarcopenic patients. Not only do they die more, they have longer hospital stays and ICU stays post-transplant. So not surprisingly, they have breathing tubes in longer, their diaphragms don't work as well, they don't get out of bed as well. They have a higher number of infections also, low albumin levels. And like I said, this connection with hepatic encephalopathy, which I find really interesting. So we can actually, there's been studies that have shown that if you treat the malnutrition, that you can reduce the hepatic encephalopathy as well. And this goes to all of those other related features that I was telling you about. So there's been studies done like with hand grip strength, like I mentioned, with all these frailty markers, with getting them on an exercise bike and doing a VO2 or a max exercise tolerance test. All of them are predictive of morbidity and mortality. This is an interesting slide from my colleague Dr. Montana Loza, who's really looked at the muscle quality area. And if you can see here, so the green is no muscle abnormalities, right, when you do the CT scan. And you can see that survival gets worse and worse and worse as you add on more problems. So when you're sarcopenic obesity, so you're obese and you're sarcopenic and you have poor quality muscle, those guys have the worst survival. So it makes sense that all of these things add on top of each other to predict poor prognosis. So with regards to an approach, I'll just start this out. This is a basic schematic that we developed when we wrote this review article. These flags are really annoying, I'm sorry. Okay, so thinking about what you're doing in clinic, what we were thinking about is all patients with cirrhosis, you need to think about malnutrition in your clinics. And there's some patients that you don't necessarily need to do a nutrition screen. They sort of skip that step. They are, hands down, malnourished. And those patient categories are the child QC, who I showed you were really, really sarcopenic, and then people who have a really low BMI. So like Dr. Ribbon said, this is not particularly sensitive, but it's very specific. So if they've got a low BMI, they're pretty much malnourished, below 18.5. Those guys need to go straight to seeing a dietitian. If they're not automatically meeting those features, then you can do a nutrition screen, which leads to, if the screen is positive, that rapid screen, go to do a detailed nutritional assessment, and your dietitian will do a nutrition management plan. If it's negative, it doesn't mean that you have to just stop there. You need to keep on repeating it at regular intervals.
Can I ask a question?
Yeah.
So on that slide, the ones that are hands down already malnourished, is that a dry BMI of less than 18.5 or a measured BMI?
We put estimated dry weight, yeah. But yeah, I suppose if they're acidic and they have that BMI, they're even worse.
Even worse.
Yeah. So.
Okay, so now I'm going to go through a little window into nutrition screening, and as we mentioned in our objectives and hopes for you guys after viewing this presentation, we're hopeful that you can now, have the skills or harness the skills to be able to screen your cirrhotic patients and identify those that are at higher risk. Because tools like SGA, although are very effective, take additional training, take more time. You evaluate more components, looking at diet records and weight history, etc., as Louisa eloquently detailed. So basically, we're going to go through a really simple screen and then try to practice our skills as well. Try to keep it interactive this morning. So who can perform nutrition screens? Basically everyone. Registered nurses, nurse practitioners, LPNs, physicians, dietitians, maybe even a social worker. Sometimes I do get calls from social workers to let me know of troubling patients. What do nutrition screening tools look at? So I'll throw a table on the next slide and just highlight a few popular nutrition screening tools. But basically, when you look at them as a family, we're looking at weight and BMI, as well as weight change, illness and extent of illness, intake, recent dietary changes, and those can be quite obtuse questions. It doesn't have to be a detailed diet history, but rather, has your intake changed in the last couple of weeks, a couple of months? Going through GI symptoms like diarrhea, early satiety, constipation, looking at their age, markers of inflammation like interleukin-6, assessing their mobility or functionality. And again, those can be kind of obtuse questions. I see you're using a walker today. How long have you been using that walker for? Appetite and fluid status, which is a big one in this population. So what are the limitations of various screens? Why are so many screening tools developed? Because not one screening tool serves every patient population. And that's the big thing that we're seeing in cirrhosis. So fluid status is not accounted for in most nutrition screening tools. And because many patients with decompensated liver disease, which those are the ones at higher nutrition risk, have some form of fluid retention, weight and BMI is just a very insensitive marker. Some require more extensive training. Sometimes the required labs, like interleukin-6, aren't part of a eMERGE panel or standard GI panel, and so we don't have that information readily available. And then the disease severity is not always considered, and that's a really big important one, I think, in cirrhosis as well, because patients with liver disease really are along some spectrum at different points in time, and so they're very dynamic. You can see them in one clinic and they're totally decompensated, and then they stop drinking, they're on diuretics, and they're actually recompensated by the next time you see them in clinic. So it's important to constantly be reassessing and reevaluating these nutrition screens. So this is the list, as promised, of some nutrition screening tools that are available. I just wanted to highlight one, the MUST, which was brought up in Dr. Raymond's presentation as well, is recommended by one of our major nutrition bodies as the preferred outpatient screening tool. But the downfall or disadvantage in this setting is that weight from fluid collections, like ascites and peripheral edema, are not accounted for, nor are disease severity. So I just touched on why that's important. And so the RFH-NPT, Royal Free Hospital Nutrition Prioritizing Tool, was developed, and it actually takes two streams. So it basically just performs the MUST in patients that don't have ascites or edema. And then the second stream is for patients with ascites and edema. And so you have grading and staging criteria in those two streams. So this is the tool. It takes only about 3 minutes to complete. And what's great about this tool in our patient population is that it has factors to account for disease severity like alcoholic hepatitis and decompensation with fluid, as well as impact on dietary intake, BMI, which is just standard routine, and then unplanned weight loss and reduced dietary intake. So this tool, I'll just go through stream number 1. If the patient, if the patient has alcoholic hepatitis or they're being tube fed, so maybe a patient in the ICU, automatically they get a 6. They get the biggest score. They are at risk of malnutrition and they should be assessed by a nutrition specialist or initiated on enteral feeding. And then step 2, however, if your patients aren't fulfilling that criteria, is to tease out the patients with or without fluid overload. If they don't have fluid overload, then it's basically a standard nutrition screen. So we look at BMI and then discuss with the patient, have you lost any weight recently? And you can ask them, what was your weight 6 months ago? Do you know it? Or do you feel like your weight has changed? Louisa brought that up. Do you feel like your clothes fit differently? I've had patients in the era of smartphones, they pulled up photos of themselves. They didn't know their weight, but they're like, check out my license photo from 4 years ago. And they're totally different looking individuals. So you can use these creative mechanisms that, again, don't take a ton of training, just being aware of that availability. And then if the patient is acutely ill or has been or is likely to not achieve adequate oral intake for greater than 5 days, then they also get additional scores. So that's pathway without fluid. Now the pathway with fluid is, does the fluid overload interfere with the patient's ability to eat? So a way to phrase that, and that sounds a little bit boring, but do you find you get fuller faster? Are you taking smaller portions? Are you taking smaller, more frequent meals? When you eat, do you feel really full or feel like you're going to throw up? So you can ask these general questions, and then you can further assess their intake by saying, has your intake been reduced by half or more over the last 5 days to get that really short-term picture. Many patients, in the days preceding a paracentesis, which if they're getting taps every 2 weeks, for example, there may be 5 days leading up to that paracentesis that they really don't feel like eating anything at all. So maybe that's an indication that they need to come in more often for a drain. And then the last question is, has the patient lost weight in the past 3 to 6 months? And so the answers to this is either no, difficult to assess, so they get a point for that, or yes. And so it kind of takes the guesswork out of, I don't know if I lost fluid or not. It doesn't really matter if it's difficult to assess, you'll still get a negative point towards your malnutrition score. Any questions so far?
I guess it's pretty easy to, they've said you need a dietitian if you're scoring 2, right?
Yeah.
So it's pretty easy to score
2 to initiate referral. Exactly. So.
And we are looking at our data on this, because we've done this in about, I can't remember how many patients, over 100, right?
Right.
Yeah. So we're looking to see whether or not any components of this might even differentiate things out a little bit easier for us.
So now we've kind of given you a window on screening, and hopefully you feel comfortable kind of maybe asking some of your patients those questions. And now I just want to give you a window just to peek in to my day-to-day life and kind of understand what goes into a nutrition assessment. So I'll try not to be too detailed here. This one little infographic on the my left-hand side here, right, is from Dr. Raymond and Dr. Tandon's review article, basically outlining the process of a nutrition assessment. So step 1 is to evaluate the patient's extent of inflammation and or cirrhosis or disease severity. What I've added to that, just in this column, is to also pay attention to their medical history. So other comorbid conditions, symptoms of decompensation, so are they encephalopathic? Do they have bleeding varices? Were they recently scoped and they're feeling like they can't swallow, for example? And then a list of their medications, and then any relevant lab work. Like vitamin levels. In our clinic, we do check a few vitamin levels with their initial clinic visit, as well as renal function and electrolyte status with being on diuretics. And then we look into dietary intake and possible barriers. And I would almost be so bold to say that the barriers are almost more important to assess compared to the intake in the explicit values of calories and protein. And that's just because if you start to frame a conversation about calories and protein to a patient that can't afford food or can't actually get to a grocery store, then it's really insensitive and very ineffective. So that's very important to assess, and I'll get a lot more into the barriers and how we assess those. And then we evaluate weight loss and BMI, so do interpretations with an estimate of dry weight, which I'll demonstrate for you guys and show you a really exciting tool on your phones. And then if they're obese, to consider specific nutritional advice with a dietary caloric restriction to maybe lose weight in a healthy fashion. And then also muscle assessment, which Dr. Tandon has alluded to, is very important to evaluate muscle change, both functional capacity and muscle mass itself.
And I guess the recent ESPN guidelines that just came out in this year suggest that everyone should be doing a muscle mass measure and a muscle function measure. So MAMC and hand grip is what they've suggested. And EASL, yeah.
Yeah, so we need to be doing more work. So, for assessing a patient's dietary intake, I just wanted to give you a brief snapshot of what we typically go through. Often I'm doing a 24-hour diet recall because we're not always prepping patients with the ability to fill out pre-populated food records. So a 24-hour diet recall is what it sounds like. I sit the patient down and I do my very best to get them to recall what they ate in the past 24 hours. Some patients have day-night reversal, so you have to be sensitive to asking the timing of their intake if they're up all night. What time did you eat breakfast might not sound quite as appealing if you were up at 4 in the morning eating a hot dog. And then the 3-day food record is a little bit more robust. And because you're getting patients to write it down, in the time that they're actually eating it, so it can be a little bit more specific, but it also comes with biases. People are writing down their food intake knowing they're going to see the dietitian. So I know if I was seeing a dietitian, I might not have that, hot dog as an example again. And then we can also use app-based tracking. So there are lots of applications online, and so you can have patients entered in if they're tech savvy. That works really well for the really motivated and tech savvy patients. And then we do an analysis of their dietary intake. So I look particularly at calories, protein, macronutrient distribution. So are they eating a 10-ounce steak once a day, or are they eating a nice protein bolus multiple times throughout the day, because that's important, which I'll get into. And then also their micronutrient intake. Are they meeting needs to support good bone health? Are they taking gigantic loads of sodium that might influence their sodium retention and fluid retention? And really, all of these methods come with their benefits and drawbacks. My little circle didn't populate. That's okay. We'll move on. So this is, as promised, the potential barriers to adequate intake. And so this is something, just an infographic to really exemplify that there are multiple barriers in patients with liver disease to achieving adequate intake. It's not just unifactorial. There's a lot of factors influencing things. So there's physiological barriers, which we discussed earlier. You guys were all really good at guessing. The ascites and early satiety, patients not tasting food the way they used to, reduced gastric capacity, sometimes they feel nauseous, occasionally even throwing up. Some patients throw up on an empty stomach, others throw up postprandially, and then impaired digestion and absorption as we went through. And then there's social barriers, which, like I said, are sometimes greater than the physiological barriers. A patient could be very isolated. They're alone, they don't want to cook for one, they're on a single income. Many reasons why that can influence intake. Eating is a social activity, and so when that's taken away, achieving adequate intake can be difficult. That goes right hand in hand with a lack of supports. The fixed income and limited finances is a big issue, and it's a social issue that we can work to break down some barriers, and sometimes we're not able to achieve, total breakdown of every barrier, but I always like to think we help. And then limited access to food. And then the fatigue and weakness plays both with the physiological barriers and social barriers, because patients that are feeling crappy, lousy, sleepy, they don't want to get to the grocery store and, make a whole bowl with quinoa and avocado and brown beans. I don't know. So in this box, I was going to ask you guys, can you think of any questions, looking at these barriers? questions that you could ask in your clinics, with your patients to address some of these barriers, even if it's just one. If you want to ask them about their finances or ask them about their appetite, how could you phrase that? Any ideas? There's no wrong answers.
Well, I always kind of go into the social aspect, so I always ask, are you working? And if not, then we go a little bit further into that, and then I ask about whether or not they got drug coverage and what their limited income is, if they have AISH or not.
Yeah, exactly. That can be really revealing.
The door.
How are you paying your bills? How are you paying for food?
Yeah, exactly. It can be a little difficult to, are there any social workers in the room? None of us are social workers, so we're not used to asking those social barrier questions, but it is so important to address, how are you affording food? Who's paying your bills? How are you getting medications? For appetite, just saying, do you still get hungry before you eat? Some patients don't. They don't have that desire to eat anymore. So for that reason, we have to strategize. Okay, how can we trigger you to eat? Because if you're not feeling it internally, we all feel it. It's noon, time to eat. These patients don't feel that trigger anymore, not as voraciously as we're used to. Oh, look, there it is.
Christmassy way.
Okay, so just a little focus in on weight and weight change. So of course, as we've alluded to, fluid status is a huge contributor to weight status in these patients, and it can really overstate a patient's weight. And I'm seeing it more and more, in pre-transplant rounds, for example. People may report their patient's BMI at 44 when really they've got 20 kilos of fluid on board. So is that a true weight status? Not really. So it is important to delineate here. And so based on physical exam by a nurse practitioner, registered nurse, physician, or by imaging, so an ultrasound report that's been done recently, or CT or MRI, typically those reports will all report extent of ascites. So it classifies small, moderate, or large. On physical exam, it might be reported as tense ascites. But I know the nurse practitioners and physicians I work with are really good at reporting in real time in the clinic, so I always get nice access there. And so if a patient is measuring small ascites, I remove 5% of their measured scale weight. With moderate ascites, it's a factor of 10% to remove, and with large or tense ascites, it's a factor of 15%. If the patient also has pitting edema, now this is what I really term as a bit of a fudge factor, which sounds horribly unprofessional, but it's really difficult to fully appreciate the extent of this edema, especially if you have a patient that has, gross anasarca, especially when they're obese. It can be very difficult to predict. So that's where you rely maybe a bit more on history. What was your weight before you got sick and how have things changed? But if they do have pitting edema that extends beyond their ankles, we say you can remove an additional 5% of their weight. So really it's a combination of data from weight history, imaging, nurse practitioner, physician reports that can be used to estimate a patient's dry weight. It's not an exact science.
It's not an exact science at all. Yeah.
And maybe a question for you, and for the nurse practitioners. How we struggle, Louise and I, sometimes in the clinic to distinguish moderate from large ascites on clinical exam. Do you have any tips in terms of how to do that?
It's a guess. I think the large tense ones are easy.
The tense ones are easy.
That's pretty easy. So something in between is moderate, and if maybe it's just showing up on imaging, then it's a ballpark way, but we need to validate this still, so it's not been validated. But it gives the patients a benefit of the doubt in that we're allowing them to say, listen, we're taking off some of the weight from the food, so you're skinnier than you are, so we're going to increase your amount of calories. So in that sense, I don't know that it's a dangerous thing to do this, but it's not going to ever be an exact science, right?
Don't you say that a small amount of ascites is not detectable on clinical exam, but on ultrasound?
On imaging, yeah,
on imaging,
that's what.
So if you've got some but they're not tense, then it's moderate?
That's exactly, yeah, that's what we do.
Yeah. So as per the conversation, it's very subjective and really, I think, more of an art than a science, unfortunately. But it can really help when you're chatting with a patient And they don't feel like they've lost weight because the scale tells them they're still 80 kilos and they've always weighed 80 kilos. And you say, but has your belly always been this distended, or you can't flex and point your feet? So that's contributing to your weight status. And so it kind of drives it home a little bit for the patient to appreciate that, oh, I have lost weight, and yeah, I do feel weak, and I probably should take care of this. So that's why, I think it is really important to evaluate.
They can
It
have
is really
time
difficult to make it accurate because it depends on the timing of the imaging, or how long ago the imaging was in terms of when you're doing your exam. It also depends on the client's goals and your diet, and the days leading up to them as well.
Absolutely, yeah. Time of the day, traveling,
But I guess the concern is if we don't take the weight into it, the fact
Oh,
that
yeah.
fluid can, influence the weight, then we'll be totally underdosing their requirements. Because they can get 10 liters, easily 15 liters, some of them off at a time. So if we imagine that was true body weight, that would be.
Yeah, just to give some
Inaccurate.
perspective for those who aren't familiar, a kilo of fluid is a kilo of body weight, which is 2.2 pounds. So, if we're looking at 10 kilos or 10 liters of fluid, then we're looking at 22 pounds difference, which, on a 60 kilo lady is quite an appreciable percentage of what their measured weight is. So it's important to take into account.
Yeah.
But we are totally right. It's very difficult to use these subjective measures acutely. So we have this lovely tool that takes all of these numbers. So what I'd like everyone to do, if you did get a chance to log on to Wi-Fi, is to type into your Google browser or Safari browser, it's www.wellnesstoolbox.ca. And just the CA, not the / calculator. I apologize, that was my mistake. That's not the actual URL, but just the Wellness Toolbox. And then just scroll down a little bit and you can go to Explore Cirrhosis Tools.
Or on the side, actually.
The
you can see
sidebar.
The little lines on the top there. We're just learning it.
But it does work with the little link on the bottom too.
Oh, yeah, you can get there a couple ways, right?
So there's the 4 lines on the right side, the top side, you can get there, or you can go in through nutrition, and then go to the nutrition prescription calculator.
Oh yeah.
Making me sign in on the UFC.
And we'll use that in your cases, right?
Yeah. So, and we can do that now if you guys, we'll give you a minute or so to
That was
set it up here.
Internet's a bit slow here, eh?
I just did.
So for those of you that do have it open, if you'd like to play along, I've got this knowledge check, kind of small case study, mini case study. And so this patient reports, this is a 56-year-old female with alcoholic cirrhosis. She reports a usual weight of 70 kilos. We measured her in clinic and she was 69 kilos, so pretty darn close to her usual weight. And she does mention, though, that she feels really quite weak compared to her previous baseline. Her height was 160 centimeters, or 1.6 meters. And so on physical exam, the nurse practitioner describes 10 ascites. So she's got a large distended abdomen. And so what is this patient's BMI using her dry weight? So if anyone's got the answer, I don't have prizes. We should have brought prizes.
We've been.
Yeah, and sure. I've got some Greek yogurt hiding in there. Anybody wants that?
So is everyone on the, did everyone get to the calculator site? It didn't work? Did anyone get there? It worked? Okay, so. Here, let me help you. Go to nutrition. Cirrhosis and nutrition and calculator. So this will make it so I hate math, so this is why we just it's so hard to remember how to do everything. But if you stick in, then you can play around with it. So you can use feet or inches or meters. But obviously Vanessa said 1.6. Then she measures 69 kilos.
Oh. Oh my gosh.
That's awesome. Not edema. Does she live on the savings schedule?
Did everyone get the answer?
She's got no edema, just tense ascites.
If you do it once, then you'll get it down for good. So.
Yeah, so helpful.
Well, otherwise we don't really translate it into our minds to do it.
Yeah, it's excellent.
Do we get a prescription?
So keep going down. Yeah, keep going down.
So even just the dry weight, if that's been spit out.
Oh, 59. 58.6.
Yeah. Exactly. So dry weight of 58.6. So this reflects an 11.35 kilogram weight loss, or close to 24 pounds, from her previous reported usual body weight. So that, weight, reporting it in that phrase to patients really can help to kind of level the severity and bring it home to them. You've lost 25 pounds. It's like a 5-year-old child, is it? Not quite. So, anyways, any questions regarding the calculator?
We'll play with it a bit more.
We'll play with it a lot more later on. So I just had to go a bit forward. We've got our horrible flags coming up.
So, Lisa, you might want to advocate for that calculator in Connect
I
Care.
think I'm going to start using it
Well,
myself.
but in Connect Care, which will go provincially, a lot of. I think this tool is external, right?
Right now,
And did you validate it?
it's it's based off of guidelines. We're gonna
So
adapt
you
it a little
could
bit.
easily put it into our EMR, so you wouldn't have to go out. Not the whole thing, because
Yeah,
it all
that's
belongs to you,
helpful.
but just the
Yeah,
calculation. Or a link to it.
yeah. Because that's what we were finding is that there's guidelines written, but nobody's actually using them because it's too tricky, especially when you have to account for fluid and everything. It gets too complicated. But we should be giving our patients a prescription.
Yeah.
This I think we can skip over.
Yeah,
We've done a lot of
we've
muscle
covered this.
function.
So really, this is just to reinforce, our process that we were discussing that we went through. So I'll actually just buzz through to carry forward. So I want to again just give you a window of intervention in cirrhosis. And again, maybe you will hear 20 things I say today, and maybe you'll take home one thing that you could tell your patients, if you like the sounds of it. Basically, interventions that I discuss with patients are based on my assessment findings. So I don't go in with my agenda. I really try to be an open book and listen to what we find out in the assessment because a one-size-fits-all approach. The mainstay of nutrition interventions, as really eloquently put in this infographic by Dr. Tandon, we know that patients need more calories than usual, up to a third more calories compared to the healthy population. We know that an overnight fast is enough opportunity for the body to start breaking down muscle, so that's an intervention opportunity to introduce late-night snacking. We know that cirrhosis ages a patient insofar as muscle composition and muscle function by about 30 years. So that's something that's important to talk about. For motivation, we want to, again, break down those barriers, which I did a lot of talking about, but that's really important. What's the barriers both to their ability to achieve their intake, but also are there barriers that exist to doing what we ask them to do? How can we help them get to where we want them to be? And also, what are their beliefs surrounding their nutrition and food choices? So, of course, if I start speaking to a vegetarian about eating chicken 3 times a day, that's not going to be very sensitive. And then behavioral skills, establishing BMI stratified, daily caloric intake goals, which I will demonstrate, and Dr. Tandon will demonstrate as well. And then calculate their daily protein requirements and more of that prescriptive late-night snack option to discuss.
Is that a question or was that a stretch? Okay. Stretch. Okay.
So I'll actually let Dr. Tandon. Do you wanna
Okay,
go through
sure, and
this?
then you can
Yeah.
do the cases.
Yeah.
Okay. So we do have guidelines, and the guidelines have been revised, but they are essentially similar. There's a blanket statement for recommended energy intake of about 35 to 40 kcals per kilogram body weight per day, and protein intake of 1.2 to 1.5. This is the old SBEN guidelines. The newer ones do suggest that there should be some reduction when you are obese, so BMI of over 30, but for everyone else that they should be taking the 35 to 40. And I think this idea of having stratification based on BMI is important, and I know you mentioned for IBD they have a sort of a set target, and perhaps obesity isn't as big of a problem in the IBD world, but obesity is really a problem in our patients. And this is me, so 5'4" and 120 pounds. My non-BMI stratified calories would be this. If I was, though, had a BMI of 41, so I kept my height, but I just ate a lot, and I was 240 pounds, you could see that the guideline recommendation would be, if you had a blanket, would be that I should be eating around 4,400 calories a day, right? So you're feeding my fat, really. You're not feeding my body. And BMI stratification makes sense to me then, because you're in a more standard range of what the calories should be. And so indeed, that's what we base the calculator on, is a BMI stratification model. BMI of 30 to 40, you get this much. BMI of over 40, you're getting less. And you added in an extra. That's exactly what that's recommended. Yeah. And so that's based on guidelines. And then using an ideal body weight for dosing protein if your BMI is over 30. And that'll be from. Does anyone have questions? The beauty of it is all of this is in the calculator already, so it's taken care of. So you don't have to remember these things.
Can I ask a question?
Yeah.
So what are we doing in our cirrhosis clinic for BMIs over 30? We're adjusting, we're using adjusted body weight.
Use adjusted body weight, 25% excess body weight on top.
Like an ideal body weight.
Yeah, it's like 25 on top of the ideal body weight.
Okay. Now, I think we won't go into too much detail on the inpatient side, but it's really essential that we recognize that any patient who's hospitalized is at high risk of malnutrition, and that if they're not eating, that within 24 to 48 hours, we need to start thinking about getting them supplemental oral. If we can't make that happen, then enteral nutrition, okay? And this guideline's excellent, actually, for just overall nutrition therapy in hospitalized patients, not specific to cirrhosis, but goes over that. In addition to making sure that they get adequate calories and adequate protein, the third most important thing, like Vanessa said, is the timing. And so an easy tip to tell your patients is to avoid fasting for longer than 3 to 4 hours during the day. And Vanessa's taught me that you just set a timer on their phone and you get them to eat every 4 hours. So if they go straight to breaking down muscle after just 8 hours, you don't want these guys to be fasting, right? So snacks are very, very important. And there's snack tips within this nutrition guide that you might be familiar with that we'll give you as well, but common options.
Yeah, like a couple slices of toast with peanut butter and a glass of milk is a really basic option. Or a cup of cereal with milk and a piece of fruit. You could do toast with cheese. I always recommend 2 food groups, just from an obtuse perspective, but trying to get that protein and carbohydrate mix. And so fruit and yogurt is another one. Fruit and yogurt with nuts is even better, depending on how many calories they require. But there's lots of options out there, but patients need to be informed, right?
Yeah.
Just need to be taught.
And it's interesting talking to my colleagues in Italy or in India, for example, where people eat supper late, and this late night snack is not really an issue, then breakfast is an issue. So it's just really thinking about culturally as well what the patient is doing and going through what their meal timing is.
Day-night reversal is another big problem. They're like, well, I don't go to bed, so when am I supposed to eat?
Yeah.
So, just working with what their typical schedule might look like, and how can we fit food into that? And maybe we set alarms on your phone so that they ring and you actually eat when you should.
And we know it makes a difference. So this was a beautiful study that they did with an isocaloric intervention. So it was 710, quite a bit, 710 kilocalories split either in the morning or in the evening as an extra in addition to whatever they were eating. And you can see they studied it across child Q classes, and the most improvement in muscle mass, this is muscle mass, total body protein, the most improvement was seen in the child Q A patients. The child QCs are a little bit more challenging to increment, but they likely maintained more. all categories increased, but they improved their muscle mass by 2 kilos over 1 year just by shifting some of those calories to the nighttime, right? So adding extra calories nighttime versus in the daytime. And we know that this late night snack, like I mentioned, also reduces hepatic encephalopathy severity. So 3 important things that you need to remember. Take an adequate amount of calories, adequate amount of protein for your nutrition prescription that pops up, and then definitely taking a late night snack or eating every 4 hours.
So how long, in terms of like the nighttime, you're obviously not recommending people to get up at 4 hours and eat something.
Some people do.
Oh, okay.
Some
So
people,
you
because
are-
these patients are up, so they put an ensure by their bedside. I worry about the teeth, but yeah, some people say keep snacks and stuff by the bedside, and actually, if you're up, eat.
Okay.
Because they're up to pee sometimes with their diuretics. I wouldn't set the alarm at night because sleep is essential as well. There is still a misconception that you need to restrict protein because it's bad for hepatic encephalopathy, and lots of docs I still hear people telling their patients that. Totally not true. This is a study done that actually looked at it carefully in patients who were admitted with hepatic encephalopathy. It randomized them to either taking low protein, just 0.5 mg per kg, 0.5 grams per kilogram, or the standard, but we recommend the 1.2 to 1.5. No difference in how they did with their hepatic encephalopathy. And even within that short period, as was pointed out, they lost muscle if you didn't give them the adequate amount of protein. There's some interesting data that's a bit far back and needs to be more studies done, and I know Dr. Raymond and I are interested in studying this, is the type of protein, and is it important in these patients? Because like Vanessa pointed out, they don't necessarily tolerate meat as well, and so the vegetable proteins might even have beneficial effects above the fact that they might tolerate them a little better. They have increased dietary fiber, and we've got these prebiotic properties that actually influence your microbiome. So we don't have hard studies in cirrhosis yet, but this is certainly something that is very interesting to try and increase the amount of vegetable protein that you suggest to your patients, even in eating lentils at some point, and introducing that concept. I don't know, what's your take on how well North American patients deal with vegetable protein?
Yeah, I would say most North American patients don't know how to incorporate vegetable proteins into their diet. So it's not always a matter of dislike or distaste. Usually I'll go with the segue of chili and say maybe make a vegetarian chili, because most Westerners are familiar with chili as a dish. And instead just sub out the meat completely and just, add 3 types of beans instead of 2.
Yeah.
But it's sometimes a tough sell. Again, patients are just really unfamiliar. They think chickpeas taste like sawdust. I've heard that a few times. So just teaching them how to flavor them, spice them, throw them into salads, and incorporate them into mixed dishes to beef them up.
Yeah, because they might have additional benefits beyond just muscle. We get commonly asked about branched chain amino acids. I don't know if you guys use it, or if that's not a common problem in the rest of the IBPs or GI world, but this is a particular problem in liver because our branched chain amino acids go down because they're being used for ammonia detoxification, and our aromatic amino acids are up. And so there have been studies done looking at providing patients with branched chain amino acid supplements. Unfortunately, they're very expensive and they're not really palatable, and so they're not used routinely. And you can get BCAAs through food as well, and so recommending to patients to increase the amount of BCAAs that they get through their food intake. So we toyed around with the concept of doing BCAA supplementation in our clinics as well. And the guidelines most recently are actually quite favoring BCAAs. They're moving towards that. So I think we'll see more studies done in that area.
What are some practical foods that are rich in branched chain amino acids?
Dairy products like whey protein is quite rich in branched chain amino acids. So whether it's milk and yogurt higher than cheese, because it's the whey protein that's a little higher in our branched chains. So when patients ask me, for example, if I'm buying a protein powder, what should I buy? If they tolerate whey products, I recommend whey because of the branched chain profile. And then poultry is like chicken and turkey are both quite high in branched chain amino acids as well.
And do you know, or are there any data that would support whole foods that are rich in branched chain amino acids compared with supplements on
Yeah.
clinical outcomes?
Not that I know of.
We don't have anything,
Yeah.
no. But it's usually about a 13 grams that they're suggesting in the supplement studies, 13, 14 grams.
Like a day that they're using.
Yeah. So micronutrients were touched on in the IBD lecture, and which ones might you think that we would test for in our cirrhosis patients?
Zinc.
Zinc, yeah. So that can contribute to dysphagia. Vitamin D, super common. IBD, all of us are probably vitamin D deficient. So vitamin D, and definitely that actually in studies of the elderly and frail patients, just vitamin D supplementation improves muscle function. So it's important across the board, immunity and many things. So vitamin D. What else do you screen for?
We check saline. Sorry?
Vitamin E, actually you do look at that, don't you? Yeah.
For fat-soluble vitamins, because if fat malabsorption is thought to be a clinical factor in that patient, we do screen vitamin A and vitamin E, and carotene actually as well, which is a slightly more sensitive marker of vitamin A status.
Are we measuring that routinely? Carotene?
In transmat.
In transmat? And then just some replacement strategies if you are deficient. As far as the zinc and selenium come up, and then obviously calcium, because bones are really, these patients are frequently osteopenic.
Vitamin A, I'm sorry, I don't know, where would you find these?
Dietary sources?
Yeah.
So, yeah,
Oh,
orange
carrots,
orange
carotene,
vegetables,
yeah,
so
okay.
carotenes, orange vegetables. Yeah, those are the best sources of it.
But we don't typically supplement vitamin A because there's some risk of hepatotoxicity with that as well. So from the diet is okay.
There's conflicting evidence and research, so I don't feel that comfortable supplementing vitamin A on its own. But in most of the Aspen guidelines, and EASL guidelines, they make a overarching recommendation that it's practical to recommend a multivitamin for daily top-up because the risk is very low, if any. The cost is quite low, and most multivitamins pack a little bit of vitamin A in retinol activity equivalent, plus beta-carotene. And beta-carotene is a lot lower risk to overdo it on because we have to convert it and activate it. So that's the practical side of things.
Multivitamin for everybody.
Multivitamin for everyone.
Iron low
Yes.
for the ones who have hemochromatosis.
So a typical low iron multivitamin is a men's seniors formulation. Is actually typically low, so like a 1 a day for men 50 and over. So I often recommend that across the board.
Now, obviously, we need to change the prescription a bit for those patients that are obese and have malnutrition or sarcopenia. The basics stay the same. You just want to change your energy a little bit. And the guidelines, and Vanessa, then I'll go to you for what your practice is, but the guidelines would say tailor it to the patient, but take off probably 500 to 800 kilocalories to try and get them to lose up to 10% body weight, which is what we know is correlated with improvements in liver histology or inflammation. And then exercising being essential as well, because when you lose weight and you're obese and you're starting to lose weight, the majority of weight that's lost is because of fat, but you're also going to lose muscle. Right, so 25% of that weight that you're going to lose is muscle. So that's why it's essential. And studies have been done looking at patients combining when you're losing weight, combining that with exercise so that you attenuate that muscle loss. Do you recommend anything differently? Would you say for when you're trying to get them to lose weight pre-transplant? Or
yeah, I mean it's really individualized. I like to say the community is confused insofar as how to feed overweight or obese individuals. And so how do we dose their energy requirements? Is it on ideal body weight, or is it an adjusted body weight? Or do we use their measured body weight and subtract calories to account for that obesity? And so I think the consensus is that there is no consensus yet. In the International Society for Hepatic Encephalopathy consensus meeting, ideal body weight was suggested as using, and then using that BMI stratified. So that's what our tool and our guidebook were based upon. And I find it works quite sensibly, but really taking a combination of what we assess their requirements and also looking at their intake and their weight history and looking at all of those factors together to try to muster up a recommendation. Best case scenario, you get your hands on an indirect calorimeter like a MedGem machine to actually measure the patient's predicted resting metabolic rate, and that way you could use that as their baseline calorie requirements and subtract calories for achieving weight loss.
Would
That's
looking,
the long story.
would looking at the rate of weight loss be helpful? Because I struggle with that too, and anything more than about 2 pounds per week, would you kind of get concerned about?
A little concerned. Yeah, I think you always want to keep things slow and steady to promote that these habits that they're building are sustainable. Any diet will work, but we need to teach patients to diet in a fashion that they can elicit lifelong. Not just until they reach their BMI threshold for transplant, not just until they get an organ, but really post-transplant as well, or without illness. So it's challenging.
And then before we go to the cases, just the last special population is the alcoholic hepatitis patients that we get asked about, because there is some data in them. So these are patients who have obviously really overdosed on alcohol and coming in with very severe inflammation to hospital. And there's been studies done looking at comparing the standard therapy, which is steroids, versus just nutritional therapy by itself, and really old data there, but there's also been studies done combining the two, which I'll show you in the next slide. This is actually a Canadian study that looked at all of these studies put together and found that in alcoholic hepatitis patients with hepatic encephalopathy, you can reduce their HE again, or their hepatic encephalopathy, but there isn't enough strong data to show that they changed mortality. This study was more recent, done in 2016, looked at randomizing patients to steroids plus standard nutrition or steroids plus sticking the feeding tube down and giving them enteral nutrition. They also didn't find a difference in the mortality rate, but they did find that patients who were getting in less than 21.5 kilocalories per kilogram per day, when I'm telling you it's closer to 35 that we're targeting, those patients died more. Okay, so there is some dose response that it looks like in the patients who have alcoholic hepatitis. I just don't think that we have the studies yet done with the right population to really define what the benefit is. There was some challenges, like we were discussing, with the tube being pulled out in a fair number of patients just due to intolerance of the tube feeding. So it's a challenge on the wards, right? It's not nice to have the tube down. What time do we have?
We have 10 more minutes.
Okay, perfect. Should we just go through a case maybe?
Yeah.
Would that be cool? Okay, let's just go through a case. And I'll hand out the guide while we're doing that. Oh, sorry. This is your case, right? Okay. So either case, or do you guys feel fairly comfortable with the concepts? We can even just ask questions or answer questions. We've been answering, I guess, along.
I was thinking that we have 10 more minutes for didactic and then another 10 minutes for
Oh,
Q&A.
perfect. Oh, that's great. Okay, let's do one case and then talk. Yeah.
Hopefully we'll keep you guys engaged and enthusiastic about these patients.
You're cute. Oh, that's the dietitian,
sorry.
actually.
Yeah, this is it. That's me. You can't tell because my hair is So we have a patient. So he's a 52-year-old male. He has NAFLD or NASH cirrhosis, and he is listed on the transplant list. He has child PUB of 8 and a MELD score of 17. So right in that mid-range transplant candidacy. He does have moderate ascites, which was performed on a recent ultrasound exam. So typically when I'm seeing patients, I see them actually the first day of their transplant assessment, which is the same day they get their imaging done. So that's beneficial to me. So moderate ascites on that day. We measured him, he was 90 kilos, and his height was 160 centimeters. So if everybody wants to play around on the calculator again, what is his dry weight? What is his ideal body weight? Because he is an overweight or obese patient, which the calculator will tell us. And what do you use to determine his energy requirements? So if anyone's playing around.
Dry weight is 81.
Exactly. Speedy. So his dry weight does work out to be 81, and his BMI with that dry weight now works out to be 31.6. So quite different. He moved from obese class 2 to obese class 1. However, because he's obese, we still use an ideal body weight as kind of a dosing weight to work out his nutrition prescription. So again, this is what is friendly about the calculator. It does it all for you because it automatically populates that we've used an ideal body weight of 64 kilos to work through his calorie goals. Did everyone advance to the nutrition prescription? Playing along? Okay, so that was a warm-up. Now, go back and let's do a little more complicated patient. So she's 56. This is the lady we actually did earlier. She has a usual weight of 70 kilos. Measured weight, though, was 69. So we've already worked through this. I'll advance the slide because we've already been there. Yeah, she had 10 ascites, sorry. No edema. Let me know if you guys are ready to move on. Sorry if I need to go back to the diaphragms. Did anyone get her prescription yet? Yeah? Okay. So I've got that screenshot. So using her dry weight, and with where her BMI is at, there's no need to BMI stratify her. We just use her actual weight. And so her daily calorie intake goals should be around 2052 to 2346 calories per day. And she's lost an extensive amount of her weight, so that's not unreasonable to try to replete some of her weight loss. And a protein goal of 70 to 88 grams per day. So this is all well and fine, but if you told this to a patient, typically they don't know what this means. So before we get into providing real life examples, can anyone think of what we should ask her to assess what she's going through with her nutrition? You know, whether she has a reduced appetite, you know, why did she lose 11.3 kilos? Anyone think of any questions? So I've drafted a few. Do you get fuller faster? Or do you find you're having smaller meals? Do any foods taste off or different? You know, if they're not eating meat anymore, they used to. Are you able to get groceries for yourself? You know, maybe if she presented to clinic in a wheelchair, you know, maybe she's not able to get around. How would you describe your appetite? Do you find you actually feel hungry before you eat? So I really like that question because the difference between feeling full quickly and getting hungry, there are two different factors. One speaks to appetite and one speaks to their early satiety. Do you ever feel nauseous? Do you ever throw up? Do you do the cooking for yourself, or do you have any help with this? You know, sometimes the patient's going to come to clinic alone, but they have a family that they support at home, or they've got a really supportive wife or husband, or maybe they have a roommate that's an all-star roommate that helps them with their day-to-day stuff. So finding out if they've got anyone else that's not in clinic with them. And then getting into the social finances. What's your grocery budget, and do you have any income support? So often I'll ask, you know, who's paying for your medications? Is it private insurance? Is it public insurance? And then that way you get information on whether they're on social assistance, AISH or Alberta Works. So I went through her diet, and this is not abnormal for anyone who thinks it's crazy. For breakfast in the morning, she had one slice of toast with jam and a black coffee. She fell asleep most of the afternoon, and when she woke up, she felt pretty nauseated, so she made herself a bowl of Lipton's chicken noodle soup, which for the record is about 1,500 milligrams of sodium. She ate 2 cups. Before she went back to bed at about midnight, she ate 1 pickle and 1 slice of toast with cheese whiz. She's on the tea and toast diet or coffee and toast diet. And when asked if this is pretty typical of her day-to-day, because it's only a snapshot, it's a 24-hour picture of her intake, she replied yes. She says she sleeps a lot during the day, she's up during the night, she just puts on the TV and stays awake and falls asleep here and there. So, I don't know if anyone wants to take a stab at her approximate intake. Anyone thinks it's under 500 calories? Between 500 and 1,000?
Yeah.
Okay. So actually 455 kcals, based on my estimate, and that's all it is, it's an estimate, but it's very low. And like I said, this isn't that untypical or atypical. And about 12 grams of protein. So remember her predicted requirements. So she's meeting a fraction, 20%, 25% of her calorie goals, and even less of that for protein. So she's doing really poorly. So where do we start, right? We've only got now 10 minutes left in clinic. So with meal spacing, this is usually one thing I'll address first. I ask patients to have something to eat a little more frequently. Aim for 3 meals plus snacks between bed. With where she's currently at, is that an unachievable goal? Maybe, because she's really only taking 3 very small meals they're more representative of snacks. She may need to eat when she wakes up in the middle of the night versus just sitting and watching TV. She may need to set an alarm to remind herself to eat, because she's just not feeling that appetite trigger. And meal replacement drinks may offer a good option throughout the night or as snacks. Let's pretend she is receiving AISH benefits, and I can provide her a prescription with that. So if finances are a barrier, meal supplements offer a really good insurance plan or bandage. Are they perfect? Are they whole foods? No, they're not. But they can fill the void in patients like these. And then I'll go into getting enough protein. So I usually tell them to eat enough protein-rich foods at every meal and snack that they have. So we'll highlight, for example, her breakfast option. She had toast with jam and coffee. So can anyone think of where the protein is in that meal? Is there any protein in there?
Maybe if there was nuts in the toast.
Maybe if there's nuts in the toast, exactly. But pretty minimal, maybe 3 grams within the slice of bread. And so I would use that meal example and say, okay, maybe we can add toast and fry up a couple of eggs. That same slice of toast, a couple of eggs instead of jam. If you want to throw peanut butter on that toast instead of jam, great. Then we get a couple of options. And then I'll provide them with a protein goal. So that's just one meal, and I'll show you the food list. And Dr. Tandon handed out the guides. And so we have a really nice protein list that goes through, patients can rip it out and put it on their fridge, and that way it's an idea. It's kind of in the middle of chapter 2.
Page 19, I think.
Thank you.
Oh, look, that's high school, 17.
Oh, that's
17.
17, right behind it. And then just to touch on reducing symptoms from ascites, I did mention earlier in the presentation, it's beneficial always to collaborate with the physician or nurse practitioner or nursing staff regarding optimizing their diuretics or paracentesis schedule. If I'm seeing a patient in the medical outpatient unit that's coming every 2 weeks for a tap, but they just told me that they don't eat 7 days prior to their tap, that's probably something we should talk about with their medical provider and get them in a little bit more often. And then to reduce ascites, I may suggest to her to reduce her intake of prepackaged foods. We won't go crazy to say a no-salt diet, but Lipton soup is potentially the worst option because it gives a lot of salt and nothing else. There's no protein, there's no limited carbs, limited fat. Okay, so this is the protein handout that I'll often go through and identify a few options for patients to incorporate into their day-to-day. So just some snapshots from our guide. So what does this look like? What would all of my recommendations? So if I had a while with this patient and she was very receptive, I might write down a meal plan like this, just a one-day example of how you meet the goals that we're discussing. So that nutrition prescription, what is that in real food? So for breakfast, we could do a slice of toast plus peanut butter, and then a couple of fried eggs, and maybe if she's got some shredded cheese, throw that in the scrambled egg mix. And then it just boosts the protein even more. Mid-morning, could she drink an Ensure Plus that we prescribe, and set an alarm for that, because after that big breakfast, she's definitely not going to feel hungry, but it's really important that she still eats. So drink an Ensure. Sometimes it helps patients to think of Ensure as more like a medication rather than food. It's a very non-romantic way to look at food, but sometimes it's necessary to adopt that stance. Later in the afternoon, after her nap, because she said that's pretty typical for her, I suggested having a tuna salad sandwich. So using canned fish, it's much more affordable, great source of protein, and you can buy low sodium canned fish. 1 glass of whole milk for higher calories, and that's it. and that's almost 500 calories. So just in that one meal, that's what she was consuming in a whole day, right? And then late night supper, because that was a later afternoon lunch. This is where we could bring in a chili, and I like one pot meals as recommendations for supper, because if she's living alone, this might feed her, if she's able to get the energy to make a batch of chili, this could feed her for 10 meals. You know, stick it in the freezer, pre-portioned, and that way she doesn't have to think about making dinner every day. And then if she is waking up in the night, I recommend snacking on some nuts, keeping those maybe at the bedside, and maybe a piece of fruit, you know, if she's going to the TV. So this total gets her, actually surpasses her protein goal, because we were just such keeners, and is about right on target for calories. So would she achieve this after one session? Probably not, but at least there's several ideas to maybe start incorporating into her day-to-day, and we can do a phone follow-up and see her in upcoming clinics. So that was that.